Okay, welcome back to part two. So this part is going to be relatively short for two reasons. One is that chapter 21, which is the next class, we're going to review the lymphatic system. And in the lymphatic system, we talk about the functions of the leukocytes from the defensive or from your the immune system. Here we primarily cover the structure. We cover the characteristics and feature of the cells that forms your leukocytes, and we talk about basic function for each of them. So it's going to be relatively short, but definitely this portion of the class is what you need to know for your labs. And then we're going to finish the class with platelets and recognizing that the main function of platelets is hemostasis, which we learned that that is the process in which your body controls hemorrhage and stops bleeding by using platelets and combination with coagulation factors, which once again in the analogy that we use, these platelets were like bricks and the coagulation factors are like the cement. You need both in order to have a good and resistant blood clot. All right, so leukocyte is a general term. Leukocyte just means white blood cell. And based on the cells, based on the granules that we can see under the microscope, we can classify the leukocytes in granular leukocytes and agranular leukocytes. Agranular, the word A means absence or without granules in the cytoplasm. So the granular leukocytes are composed by three: neutrophils, eosinophils, and basophils. Agranular, monocytes, and lymphocytes. As you know, lymphocytes, we have T lymphocytes and B lymphocytes. There are other lymphocytes called the natural killers, but for this class, we're not going to mention them a lot. And then, as you remember, the Buffy code, which talked about this in last class, the white blood cells are an important component of the Buffy code. And every time you have an infection or a cancer, this Buffy code will increase. Okay, the trick here, so you don't get questions wrong in your exam about this one, because if you're gonna get something wrong in the exam about blood, is going to be how to identify neutrophils, eosinophils, and basophils, because you need to know what to look for in order for you to be able to identify them very quickly. First, neutrophils, this part kind of repeats. Eosinophils, basophils, neutrophils. So when you see this word neutrophils, I want you to think about the first portion. Okay, and just remember that these ones are the ones that has granules. So therefore, this is the main focus part. When you take a blood sample and put the blood sample in a microscope slide and you do what we call a blood smear, you have to stain the blood. And depending on the staining, depending on the ink that you use, some of these granules will turn blue or some of them will turn red or orange, and other ones will not pick that stain. So the ones that do not pick that stain very well, they're called neutrophils, and you think about neutrophils as neutral, meaning that they will not color the granules blue or red. They're more neutral. So they will look like this in a model. So remember basic anatomy of the cell. The cell has nucleus. This is the cell membrane. In purple, we have this nucleus, which is a nucleus that is very peculiar because it doesn't look like the typical circular nucleus that we normally represent. And in fact, notice that another name for neutrophils is polymorphonuclear cells. And I know that sounds all fancy, but it's not really. Poly just means many, morpho means form or shape, and then nuclear means nucleus. So it's a cell that has a nucleus that has many shapes, okay, or that looks uh, that has like yeah many shapes. That's the best kind of translation. So polymorphonuclear cell is all this despite they look like you might have here four nucleus. In reality, it's just one nucleus that has different shape. That is the very unique characteristic. But again, another thing to look for is that see all these kind of little dots that you can see there, they have the same color than the cytoplasm. In this case, it's like a light brown, right? I mean, I'm doing this with my stylus here, and now they look red. But in reality, if you see, the granules do not color. They have exact same color than the cytoplasm. So this is how it looks in the model. This is how it looks in the cartoon, and this is how it looks in a real picture, right? These ones are red blood cells without nucleus. The smallest cell or the smallest form element in the blood are platelets, and they're very little tiny. They're even tinier than a red blood cell. And then we have the polymorphonuclear cell that again, it looks like it has several nucleus, and then the granules do not stain very well. You will see the difference now that we review eosinophils and basophils, and you will see those granules that I'm talking about. And I'll give you a strategy for you to be able to recognize them. What else do you need to know? That from all the white blood cells, neutrophils are the most common type of leukocytes. Once again, overall, the most abundant cell in the blood are red blood cells. But from the leukocyte, from the white blood cells, neutrophils are the most abundant type. And when they increase in number, most of the time, that represents a bacterial infection. So they typically, whenever you have an infection that involves a bacteria, those are the ones that when you do a blood test in the patient, you will see that the white blood cells are high, and then you're going to see the differential, which specific white blood cell is elevated. You will see that the neutrophils are the first ones to elevate and respond uh, to bacterial infections. The second out of the three granular leukocytes are the eosinophils. Okay, eosinophils, those are cells that they part of the immune system. They typically elevate during allergic reactions, or if you have allergies, or parasites. So what that means is that somebody with asthma, for example, whenever you take a blood test, sometimes you might see the percentage of eosinophil is not that much. So they do not represent a lot. That your white blood cells, normally the values is like between 1 and 2% of the leukocytes. But when you start seeing like 5%, 6%, 8%, that means that there's an elevation of eosinophils. And just by looking at the number, even if the patient doesn't have symptoms, that means the patient either has allergies or a parasitic infections, or sometimes autoimmune disorders that also react like an allergy. What do you need to know for your labs? How to recognize them. And the way how you recognize those is based on the color. So the granules, they're going to have this kind of red to orange color in the cytoplasm. So if you look at this picture, these ones are the granules that I'm talking about. Now, this is the model. And again, you can see here, these red dots. So the cytoplasma is light brown, but the granules are more kind of red orange. Now, my suggestion is to memorize the next cell, basophil, which is going to be easier. And I'll tell you why in a minute. Okay, basophils are the cells, is the last granular leukocyte, and is the less common, is the more rare. But my recommendation, the easy way how you can get these points easily in the exam is to recognize this. Whenever you have a granular leukocyte, you have three options: neutrophils, basophils, or eosinophils. The only one you need to remember is basophils. Why? Because, see, basophils, B stands for, you can think about B for blue. Neutrophil is going to be easy for you to remember. Neutrophil, neutral, they do not stain in color. And the one that stains in blue is basophil. Therefore, whatever is the other one, whatever the granule, if it's not blue and it's color, there must be an eosinophil, which again stained in red. So the easy way to memorize this is basophils. They have blue stain. They increase in amount in also allergies and parasites. And the main difference is that they contain heparin, histamine, and heparin is an anticoagulant. Now, for your lab, you're not going to require to know all that, basically the color. And if you look at this model here, you can see whenever you see these little blue dots, blue basophil, and this is how it look in a real blood smear. Right. The other groups are those called agranular leukocytes, and those are going to be easier. You're not going to look for granules because they do not have granules. So they have other characteristics, other features that you're going to look for when you see pictures or when you see them under the microscope. You know, monocytes are they're the biggest or largest white blood cells. And if you pay attention to what it says here, you know, macrophage. We mentioned macrophages when we talk about red blood cells that were 120 years old. They reach the spleen, and macrophages are the ones that are in charge to destroy those old red blood cells. But macrophages are monocytes. So what's the difference here? So when you have a monocyte, is when the cell is still in a blood vessel. But if a monocyte leave the blood vessel to enter a tissue, they become macrophages. So I'll repeat it one more time because it's important. A monocyte is called a monocyte when it's in the bloodstream, in the blood vessels. If you have monocytes in the liver, so in the tissue, not in the blood cell, they're called macrophages, and specifically they're called Kupffer cells. If you have macrophages in the skin, they're called Langerhans cells. If you have macrophages in the brain, they're called microglia. So it all depends on where is the macrophage, in which tissue, the name might change. The point here is that monocyte macrophages pretty much are the same thing. So macro means big, and phages means that that is how they destroy bacteria or all cells, is by swallowing them and then releasing the lysozymes and enzymes that will destroy them. How you can identify those in the microscope? First, whenever you see all these other cells, the huge one, the biggest, the largest one in size is a monocyte. But also, you need to look for the nucleus, because the nucleus has this very unique U-like shape, or sometimes this is referred as a horseshoe-shaped nuclei. Okay, so this is the main characteristic, the letter U. Right, this is how it looks in the model, and this is how it looks in a real blood smear. And you can see again a big, huge cell without granules and with these horseshoes or U-like shaped nucleus. That is a monocyte. Normally, when they elevate, is when conditions like tuberculosis, fungal infections, or leukemia, so more chronic diseases. So to recap, neutrophils, acute bacterial infections, basophils, and eosinophils, they tend to elevate during parasitic disorders or allergies, and monocytes, they elevate in chronic diseases like tuberculosis, fungal infections, or leukemia. Okay, the last category of the leukocytes, the ones that do not have granules, are the lymphocytes. Now, I told you before, the most important lymphocyte to remember is the T lymphocyte or T cell. This is the most important one, and you can think about this just by thinking what HIV is, right? So, human immunodeficiency virus is a virus that people that dies from AIDS and HIV is not because the virus itself. The thing is, the virus destroy this specific white blood cell. It targets that, and there are even conspiracy theories about the HIV being a virus that was made in a laboratory, because for some reason, is HIV destroyed the most important cell of the immune system, and then by attacking that specific cell, all your immunity just goes to the toilet. And patients ending dying not from HIV but from other diseases that normally your body will take care of it and destroy, and you will not get sick. But you can see here, just with that example, why the T lymphocytes are the most important cells. We mentioned B lymphocytes. Those are the ones that produce antibodies. And once again, don't let don't make this mistake in the exam. Whenever you're taking the exam, B lymphocytes and plasma cells are pretty much the same thing. It's just that a plasma cell is a cell that has been activated by a T cell, and now they're producing specific antibodies. But a B lymphocyte is also able to produce antibodies. So both of them are the cells that make antibodies. The last one is called a natural killer cell, and those are part of the innate immune system that are capable to destroy cancer cells or viruses, but they're not as good as the T lymphocytes, or they become way better. There's a specific type of lymphocyte called cytotoxic lymphocyte that are better killing cancer cells. Now, how they look under the microscope. You're not going to be required to know specifically the difference between a B cell and a T cell under the microscope. But in reality, they're relatively small cells with a circular nucleus. So remember, the monocytes, they're huge with a horseshoe nucleus shape or like U shape. Lymphocytes, as you can see in a real blood smear, they're relatively short, but they have a huge nucleus compared to the cell, and the nucleus is more circular. And it makes sense that they have this big nucleus, especially when you think about that those are some of the cells that produce antibodies. This just summarize what we cover. Acute bacterial infections, neutrophils, think about neutral, so no color in the granules. Allergies and parasites, eosinophils and basophils. Think about B for blue. Look for those blue granules. Eosinophils, well, look for the color, whatever other color is. So in this case will be red or orange. Monocytes and lymphocytes, they do not have granules. Monocytes are the largest ones. They're like rhinos, right? They're huge, and they have this U-shaped nucleus. And lymphocytes, they're subtypes. For your exams, you just need to know they're small. They have a big nucleus compared to the cytoplasm, and it's around. Now, lymphocytes, usually, they elevate during viral infections. Okay, just to complete this I will say, introduction to the white blood cells, because you will see that it's more complex. And next class, we're going to review all the details of these white blood cells. Here, we're just basically touching the tip of the iceberg. So, characteristics. Something that is important is, imagine when you have an infection in a tissue. In order for your body to immune system to clear that infection, your white blood cells, they have two ways how to arrive to the tissue. One is using blood vessels, right? And the other is using the lymphatic system, which we're going to cover next class. Now, for this, we're going to focus in this part just to the characteristics and how these white blood cells move. And we talk about them a little bit when we review the paracrine secretions. Whenever you have an infection, let's say this was the skin, you have bacteria growing here, you might have some white blood cells that they just live in the skin. Those white blood cells release chemicals like histamine, that they're chemicals that attract white blood cells. They're called positive chemotaxis. So positive chemotaxis is chemicals, they're like pheromones, they're like perfume, something that cells, especially white blood cells, get attracted to. So once a white blood cell reach the area where more of these chemotaxis are concentrated, then there's a process called diapetesis, which is the way how these white blood cells squeeze through the endothelium, which are the cells that form your blood vessels, and they reach the area of infection, and then they start attacking and destroying whatever cell or pathogen is affecting your tissue. There are some medical terms that you need to know about these leukocytes. The term leukopenia, okay, which means you have a low or few leukocytes in your blood, so a decrease in lower account. The opposite of leukopenia is leukocytosis, right? And by the way, just as you know, leukopenia, it can be a sign of a viral infection. There are some viral infections that your body initially responded with leukopenia, and then after that, you have leukocytosis. Leukocytosis, again, is just it's a general term just to say that you have an elevated uh, white blood cell account. Now, then what you need to know is whenever you have leukocytosis, you need to see which ones is the one that is more elevated. So, for example, if I tell you that a patient has leukocytosis and from 100% of all the leukocytes that are elevated, that 80% of those let's just say that um, okay, let's just put here, I'll give you numbers. Let's say that the neutrophils, they are 20%. Let's say the lymphocytes, they're 70%. And then let's say the eosinophils and the basophils and the monocytes are the rest, altogether 10%. So what infection do you think it might be in this case? Or a patient that has lymphocytes elevation uh, predominantly, that make you think viral infection. If it's again the neutrophils, they are the ones maybe 80% versus 20, that tells you, oh, neutrophils, bacterial infection. Or if you start seeing eosinophils and basophils or monocyte elevation, uh, then you say, well, maybe it's allergies or parasitic or chronic diseases. Now, the term leukemia and lymphoma is something that even medical students sometimes confuse because both are cancers related to with the immune system. So leukemia and all is about the location, the origin. So leukemia are cancers that the origin is in the bone marrow. So you start producing all these white blood cells and they start circulating into the blood, and that is what we call leukemia. It's a type of blood cancer in which you have a bunch of white blood cells that are not doing anything. They're making your blood thicker and they cause more damage than something else. Even though these leukocytes, they don't think that they protect you against infections, because most of them, they're cells that they're not even functional. They're just producing and multiplying. And by doing that, you're investing, a lot of your resources are being wasted. And plus, then the symptoms are related with the lack of production of red blood cells or the lack of productions of um, platelets, because the bone marrow is so busy making copies of uh, white blood cells in a cancer called leukemia. Now, lymphoma, the origin are lymph nodes, the spleen. So this is the place where T cells and B cells normally are located. So lymphoma is a type of cancer in which lymphocytes, either T or B lymphocytes, they start getting multiplying without a control, but the origin is lymph nodes or part of the lymphatic system. Now, leukemias, you can have a leukemia with an excessive amount of B cells or T cells, but the thing is the origin of the cancer is the bone marrow, and then you have white blood cells circulating the blood that way. Most of the time, lymphomas present as masses, like this one in this patient's neck. That they're painless and they're just in large lymph nodes, and then those lymph nodes, you go to the doctor, you have a node, and they take a biopsy and they look at those cancer cells. Those are lymphomas. All right, let's finish the class with this last part of these form elements. Those are the platelets. Platelets, also known as thrombocytes. Remember that they're not really cells, they're fragments of this huge cell called megakaryocyte, and they're extremely important to limit blood loss through the process called hemostasis, which is blood clotting. So the key information to memorize here: connect megakaryocytes with thrombocytes or with platelets, and know that the platelets are extremely important for hemostasis. Thrombocytosis, increase in amount of platelets. Thrombocytopenia, a decrease or insufficient number of platelets. Without platelets, you will not bleed. So if you have a severe thrombocytopenia, that might lead you to have bleeding problems. The process of hemostasis: when you hurt, when you have a wound or a blood vessel that is injured, the very first reaction, the very first step that your body will do to control the hemorrhage is like almost a reflex, is vascular spasm. Okay, so vascular spasm, before your tissue, before your blood vessels try to make a blood clot, the first thing you're gonna do, and this is chemicals, is based on chemicals released by the cells that are close there, is vasoconstriction. What kind of chemicals? Well, the ones that we have here: serotonin, prostaglandins, and phospholipids are the ones that trigger vasoconstriction, which is the first thing that happens, vascular spasm. Almost immediately, the next response, it will come from the platelets, and we're going to have the platelets plug or platelets plug formation. This is just temporary, meaning these platelets are good stopping the hemorrhage, but it's insufficient. So this is kind of is sometimes is referred as primary hemostasis. Now, the secondary hemostasis is what is going to consolidate the blood clot, which is going to be definitive by stopping uh, the bleeding. So as we can see here in this representation, once you have some of these platelets that has been activated, positive feedback loop triggers the release of more chemicals that would attract and activate more platelets to form a primary uh, plug or primary hemostasis. This is what we call the platelets plug. At the meantime, the most important step to have a solid blood clot is the process called coagulation, which is associated with the protein. Remember the protein that we talked about earlier in the first part? Fibrinogen was one of the three plasma proteins. The whole point is to convert fibrinogen into fibrin. And this fibrin is the active version, the one that will seal and will work as a glue to stick red blood cells and platelet together, and that's what we call a true blood clot, what we call a secondary hemostasis. That is the one that is going to be the definitive. We are almost done. The last, there's another process called fibrinolysis. So fibrinolysis is the process of breaking down fibrin or degrading a blood clot. Now, in the same way how fibrinogen is the inactive version of fibrin, plasminogen is the inactive version of plasmin. Plasmin is what degrades and breaks down fibrin. In fact, this plasmin is something that we use when somebody has a stroke or a heart attack. There's this called the TPA. TPA is basically a synthetic version of this plasmin that will dissolve, if you will, instead of using that fancy break down the fibrin, just dissolve the blood clot. That is the main function of plasmin. There's just two more concepts to know, and that will conclude the class. Is the thrombosis, okay, disorders of coagulation or clotting. Thrombosis refers to the fact of making a blood clot in a blood vessel that is not damaged or that is minimally damaged or is almost intact or slightly damaged. So really, we should have blood clot formation just when you have a rupture of a blood vessel. But if you're in your veins, if you have white red blood cells and platelet activation forming a blood clot when it's not necessary, that's when we call thrombosis, and specifically that is called a thrombus. So a thrombus can form with an intact or only a slightly damaged blood vessel. So a thrombus is abnormal. What's the difference between a thrombus and an embolus? So an embolus is a thrombus that breaks free and now is traveling through your veins or through your arteries and will reach uh, somewhere, will go somewhere. The most important example to remember is DVT or deep vein thrombosis, which is a disease that increases the risk to developing pulmonary embolism. What that means is people who has vein insufficiencies, right, in the veins. Again, the details about these valves and this is something we're going to cover in the class, cardiovascular. But when people damage these valves in the veins, blood start accumulating and you can have a thrombus. If one of those thrombus breaks free and circulates through your blood, now it's not called a thrombus. Now it's called an embolus. And that embolus will go up through your veins, will reach the inferior vena cava, then will go to the heart, and then from the heart will go to the lung, and that is when it causes pulmonary embolism. And that concludes our class in blood.